Headache is a common presenting complaint in both primary and secondary care. It is the 7th most common presenting complaint in primary care and is one of the top 3 neurological causes of acute presentations to hospital. In this video, we will cover primary and secondary headaches as well as diagnostic features, investigations, and management of headaches. There are some key red flags associated with a headache indicating a possible serious underlying cause. Fever, photophobia, or neck stiffness may be indicative of meningitis, encephalitis, or brain abscess. New neurological symptoms could imply a hemorrhage or tumors. Visual disturbance can lead you to suspect giant cell arteritis, glaucoma, or tumors. Sudden onset occipital headache can be indicative of subarachnoid hemorrhage. A headache that's worse on coughing or straining, worse on standing, lying, or bending over, or causes vomiting is indicative of raised intracranial pressure. A headache that occurs during pregnancy may be indicative of preeclampsia. Primary headaches are those with no identified pathology such as migraine or tension-type headache. These are by far the most common types of headaches. Secondary headaches are those which are secondary to organic pathology. Most headaches seen in clinical practice are primary headache. However, a small minority of patients will have secondary headache. It is important to be able to identify red flags suggestive of organic pathology. Now let's dig into primary headache. The commonest primary headaches are tension-type headache and migraine. Less common primary headaches are the trigeminal autonomic cephalalgias, a family of 4 disorders which includes cluster headache. Migraine headaches are primary headaches that are characterized by recurrent episodes of moderate to severe throbbing pain, usually on one side of the head, that lasts from 4 to 72 hours. They are often accompanied by nausea, vomiting, photophobia, which is the sensitivity to light, and phonophobia, which is the sensitivity to sound. Migraines are more common in females than males with a 3:1 ratio, and the onset is usually from adolescent age to early adult life. Family history of migraines is common in up to 70% of patients. Some people may also experience aura, which are sensory disturbances that precede or accompany the headache, such as visual flashes, zigzag lines, blind spots, tingling, or numbness. The pathophysiology of migraine has been studied for decades. Various mechanisms and theories have developed. It is a likely combination of structural, functional, chemical, vascular, and inflammatory factors. Now let's talk about the triggers. Migraine triggers vary between patients and may include stress, bright lights, strong smells, certain foods like chocolate, cheese, and caffeine, dehydration, menstruation, disrupted sleep, and trauma. Migraines are made worse by simple exercise, and patients with migraine prefer to lie down in a quiet, darkened room. Migraine headaches are diagnosed based on the criteria of the International Headache Society, which include frequency, duration, intensity, location, quality, and associated symptoms of the headache. Migraine headaches are treated with a combination of acute and preventive medications as well as lifestyle modifications such as avoiding triggers, managing stress, and maintaining a regular sleep schedule. Acute medications include analgesics, anti-inflammatories, triptans, and antiemetics. Preventive medications include beta blockers, calcium channel blockers, anticonvulsants, antidepressants, and monoclonal antibodies. It's important to know that triptans work best when taken early and are contraindicated in heart disease. Let's talk about cluster headaches. Cluster headaches are severe and unbearable unilateral headaches usually centered around the eye. They are called cluster headaches as they come in clusters of attacks and then disappear for extended periods. For example, a patient may suffer 3 to 4 episodes a day for weeks or months, followed by a pain-free period lasting several years. These attacks last between 15 and 3 hours. A typical patient is a 30 to 50-year-old old male smoker. They may have triggers such as alcohol, strong smells, or exercise. They are often accompanied by autonomic symptoms such as lacrimation, which is tearing, conjunctival injection, which is the redness of the eye, nasal congestion, rhinorrhea, which is a runny nose, ptosis, which is the drooping of the eyelid, miosis, constriction of the pupil, and facial sweating. Cluster headaches are more common in men than in women, and they typically start between the ages of 20 and 40. Cluster headaches are thought to be caused by the activation of the hypothalamus, which is a part of the brain that regulates the circadian rhythm, the body's natural clock. This activation leads to the release of histamine and serotonin, which stimulate the trigeminovascular system and cause pain and inflammation. Cluster headaches are diagnosed based on the criteria of the International Headache Society, which include the frequency, duration, intensity, location, quality, and associated symptoms of the headache. Cluster headaches are treated with acute and preventive medications as well as oxygen therapy, which can abort an attack within 15 minutes. Acute medications include triptan, which are given subcutaneous or intranasal. Preventive medications include verapamil, lithium, and valproate. Now about tension type headaches. Tension type headaches are the most common type of headache. Stress and muscle tension are often factors in these headaches. Tension headaches typically don't cause nausea, vomiting, or sensitivity to light, but they do cause a steady ache rather than a throbbing one and tend to affect both sides of the headache. Tension headaches may be chronic, occurring often or every day. They feel like a tight cap or a band around the head, pressing or tightening the pain in the head, neck, or shoulders that last from 30 to 7 days. They are often associated with stress, anxiety, fatigue, or poor posture. Tension headaches are thought to be caused by the contraction of the muscle of the head and neck, which may be triggered by psychological or physical factors. Tension headaches are managed with reassurance, analgesics, anti-inflammatories, muscle relaxants, and tricyclic antidepressants. That is it about primary headaches. Now let's talk about secondary headaches. Secondary headaches give a similar presentation to a tension headache, but with a clear cause or an underlying illness leading to the headache, such as a medication overuse headache, post-traumatic headache, cervicogenic head, which originates from disorders of the neck or cervical spine, sinus headache from the inflammation of the sinuses, often due to sinusitis, hypertension-associated headache, infection-related headaches, headaches associated with various infections such as meningitis or encephalitis, secondary headaches due to cranial or cervical vascular disorders, or secondary headaches due to substance withdrawal. It's important to note that proper diagnosis and management of secondary headaches require a thorough evaluation by a healthcare professional. If someone is experiencing recurrent or severe headaches, seeking medical advice is crucial to identify the underlying cause and determine an appropriate treatment plan. There are 4 evidence-based indicators for a secondary headache. Number 1 is thunderclap headache. Headache with onset which reaches maximal intensity within a minute to 5 minutes of onset. This is the most likely headache phenotype to have a secondary precipitant. This presentation is an indicator of a potential acute vascular pathology, one of the most serious of which is a subarachnoid hemorrhage. We will talk about SAH in another video, so stay tuned. Other potential differential diagnoses include meningitis and hypotensive pathology. Number 2 is an associated focal neurological deficit. Neurological deficits may include unilateral limb weakness, cranial nerve abnormalities, or sensory deficits. Neuroanatomically, this suggests that there may be a lesion that is altering the way that individual nerves, spinal or intracerebral tracts are functioning. Number 3 is an associated systemic feature. Systemic features may include fever, weight loss, night sweats in conjunction with recent onset and progressive headache. It is important to exclude temporal arteritis or giant cell arteritis, a pathology that can cause permanent visual loss if untreated. Other differentials include malignancy or chronic infections. Number 4 is patients over the age of 50. Headaches in patients over the age of 50 can be indicative of giant cell arteritis, also known as temporal arteritis. It's a chronic, systemic, and potentially serious inflammatory disorder affecting medium and large arteries, particularly the temporal arteries. This condition predominantly occurs in individuals aged 50 and older, with a higher incidence in women. Giant cell arteritis will be discussed in detail in one of our upcoming videos, so stay tuned for that too.
That is all. Thank you for watching. Show us your support on Patreon, subscribe for similar content and click that bell icon. Don't forget to check out this playlist and follow us on Facebook, follow us on Instagram to stay tuned. Minute Med, where medicine is made fun.